Well, good morning, everyone. My name is George Griffin. I was the past president of the Federation of European Academies of Medicine, and it's my pleasure to introduce this this seminar program today and discussion. Tell you a little bit about the forum, and then I will hand over to everyone who is a participant on the discussion panel, just to introduce themselves briefly. The FEAM, of course, is the Federation of European Academies of Medicine, and the forum is a group which has been initiated about 2 years ago, mixture of academe, industry, patient groups, MEPs, the European Commission, looking at important issues facing clinical medicine and healthcare in Europe. And we have at least 3 meetings a year with distinguished panels and speakers, and also contributions from the EU, as you'll see today. Now, as I said, my name is George Griffin. I'm a physician scientist, and as part of my work at St. George's Medical School in the University of London, in fact, I founded a vaccine research institute, which has looked at mucosal vaccination initially, and has looked now at several of the COVID vaccines. And COVID, of course, has had great implications for healthcare in the EU. And I know in the UK, we now have a 3-year waiting list for some of the elective procedures, particularly orthopedics, of course. And the COVID vaccination routines have been a fantastic example of rapid response, and we'll be discussing whether or not it was rapid, of course, later on, but also made us think of the future. But one of the things it has done, in addition to reducing the accessibility to healthcare in other disciplines, has been the effect on routine vaccination procedures. And they are principally, as you hear, of course, in childhood, but of course now in adult vaccination. And we will be issuing a statement soon on adult vaccination in the UK and just how important that is, and looking also at the aging immune system. But that's something we can talk about later. So without further ado, I think we should start. And I'm delighted to introduce Sibylla, who is going to tell us about the current position in Europe. And she's going to talk about the current position. She is from Vaccines Europe. Sibylla.
Thank you very much, George. Thank you everyone for the opportunity to speak today. Just very briefly, with regards to Vaccines Europe, we are what we call a trade association representing the vaccines company. And we are celebrating our 30 years anniversary today. And our mission is really to drive a sustainable and resilient vaccine environment in Europe by protecting the population against vaccines-preventable diseases at all stages of life. And I've been asked to present today what is the situation of vaccination, routine vaccination, in the context of COVID-19 pandemics. Just with regards to the presentation, if someone is putting it on the screen.
Ruben?
Yes, let me.
So as I mentioned, just to go through, we will discuss right now about how COVID-19 pandemic disrupted, in fact, routine immunization. So just going back through the presentation, I will touch upon what we call routine immunization or vaccination, what this actually means, what we know about the impact of the pandemics with regards to routine immunization, why we are in the situation we are in today, and what can be done to change actually to ensure that we are not getting in the same situation in the future. So do I have access to it, Ruben, or you do it in the end?
Yes, we see on the screen, Atilia.
So yes, no, but Ruben, please do the slideshow for me.
Right, who is changing slides? Are you doing that?
I don't have access to it.
Right, Ruben?
Yes, I'm changing the slides, yes.
Good, that's right, thank you.
Next one. So what we are calling routine immunization is important to know that routine vaccination or those vaccines or vaccinations that are recommended for defined eligible individuals at national or subnational levels. Basically, they are vaccines at all stages of life, whether you're a kid, an adolescent, an adult, or another adult, because depending on who you are, where you live, the type of occupation you have, etc., there is a good reasons to be protected against preventable infectious diseases. So in Europe, in terms of recommendation, what countries can actually provide to their population is up to a protection against up to 20 infectious diseases and related cancer throughout the lifespan. So you have those vaccines available for the different stage of your life, if you want, on the screen. Not mentioning them into the details, but I think it's important to understand actually the broad range of vaccines available to protect the population. And it's one step to have those vaccines recommended. It's another step to have them publicly funded. And when we look at how things are in Europe with regards to immunization policies, there is a huge fragmentation, in fact, across the countries, between the countries. So not all countries provide the same level of protection to the citizens. And if I just take the example with regards to funded vaccines, with Romania, as a country that provides the smallest number of vaccines to its population with 8, compared to Italy or Greece, for example, that provides up to 18 vaccines today to the population free of charge. Next slide. So COVID-19, we have heard it a lot, is having a significant impact on routine immunization, leading to a decline in the vaccination coverage rate. And this has been due to the lockdown that has been put in place, the social distancing measures, and we have alerted actually following the first lockdown, but not us only, all the scientific societies, healthcare providers, about the issue that everybody was saying with the national immunization program being disrupted, restrained, or even completely suspended right at the beginning of the pandemic. And all this concern was very quickly raised, and we've seen national and international organizations really taking a good stand with regards to the need to resume as quick as possible those immunization programs and ensure that all catch-ups are happening very, very quickly to protect the population. Otherwise, we may end up, once the lockdown are finished, with pandemics or outbreaks of other diseases, such as measles, for example. And what we've seen is actually, we know that at least 80 million of children worldwide have actually missed some of their vaccination. And for some of those kids, it's going to take a long time actually to recover. So a big of concern. That said, an amazing coordination among all the relevant organizations to call the government to resume the programs. And we know that this worked very, very well because most have been achieved in the pediatrics field today. Next slide. So here is just a survey that actually the colleagues from Attila could actually present. But if we just look at, for example, the behavior of the parents during this lockdown, with regards to the vaccination of their kids. If we just look at meningococcal vaccination, for example, in a survey that covered about 5,000 parents across the world, including several countries in Europe, half of them actually mentioned that they had cancelled or delayed their child's schedules with regard to meningococcal vaccination during the pandemic. And this was either due to the country lockdown or the stay-at-home regulations for most of them, concerns of catching COVID-19 in public place, so really concerned about the safety in access to vaccination in the context of the pandemics, or the need to stay at home actually to take care of someone that actually contracted COVID-19. So a situation that was clearly complicated for the parents to manage in the context of the pandemic. Next slide. And if we look at a little bit more in details about the reduction in vaccination rates for what we could actually collect, we've seen that in France, for example, here is a table that provides the number of vaccines delivery that has not been achieved from September 2020 versus what would have been actually expected. And it seems that whether it is for the infants, whether it is for the children with measles, mumps, and rubella, or the hexavalent vaccines, there is a significant actually number of kids that did not receive their vaccination as of September 2020. And if we look for the adolescent as well with HPV vaccination, the number is huge, is over 150,000 of deliveries that has not been proceeded. For the infants, it's been a massive with over 600,000 of DTP, diphtheria, tetanus, polio, and goes with that would not be delivered. So a significant number of kids and adolescents that did not receive their vaccination. In Greece, the same. What we actually see and acknowledge that post-first lockdown with the engagement of the scientific and healthcare providers society, the vaccination actually increased significantly, reaching closely 80%. But the second lockdown in November 2020 gave a second cut actually in those coverage, and the children and adolescent vaccination coverage rate fell again by 40%. So a significant issue, and today, February 2021, so earlier this year, clearly the adolescents did not receive any vaccination at all in Greece. Next slide. And this was seen in other countries. So there are key data here with regards to Italy, Spain, and Netherlands, are less affected, honestly, by the issue. But it's important to notice that there is large variation among countries, and that the declines also not all caught, because we have an issue with regards to access to data for some countries where COVID-19 created a disruption with the affected capacity to collect those data, because a lot of this has been actually transferred, in fact, to COVID-19 as well. So we have few data, I have to say, with regards to the impact of COVID-19 pandemics on children vaccination, adolescents, but what about adult vaccination? And in fact, we don't have much. We don't have much because the data are simply not available. So we have an issue here in terms of data collection, data access, and ability to understand where we are at with regards to adult immunization and whether any specific actions should be taken on this particularly. Next slide. So why are we here? So here is just actually a map, is back to 2020, but collect actually the data on a specific month for pediatrics. Pediatrics for meningococcal vaccines, for instance, but also with measles, the combined meningococcal and measles vaccine. And the area where I want to show this map is that the countries that are in white are basically the countries that could not provide monthly data here in pediatrics. So it's just the issue is that we don't have timely monitoring available for mass vaccination, in fact, in Europe, and it's hardly available beyond pediatrics at all. Next. But we know, and this is the lessons learned from COVID-19 and also what we need to leverage, we know that we can do things differently today. We actually managed to have timely monitoring with regards to COVID-19 vaccination across Europe. We managed to reach the 70% full course vaccination of COVID-19 in 9 months. This is incredible. And this is worth saying that has never been achieved for influenza in decades, despite a huge quantity of recommendation by all the stakeholders and all European institutions as well. So something to take on here is that we can do things differently from now on to ensure timely monitoring for all relevant vaccines. Next. Why we are here as well, I mean, we cannot diminish the influence of vaccine hesitancy, which remains actually the main barrier to access to vaccination. And vaccine hesitancy is a complex phenomenon, which is not only about trust in the product, it's part of it. So you have confidence. That is clearly an issue with regards to understanding well vaccines, how they play. Trust in the health systems and in the policymakers, so health systems that delivers the vaccines and the policymakers supporting the immunization programs. It's about constraints, or what I would call convenience in access for the people to be vaccinated is actually the system at ease for those individuals, whether they are kids, adolescent, adult, or other adult to have access. Can you go anywhere to have access to your vaccination depending on who you are, or is it a massive effort for you? Is it free for you to access vaccination or not? So all of this plays a significant play in the access to vaccines. Complacency, whether I feel at risk. Calculations, that it's about where you actually look for data to take an informed decision. And do you feel responsible to protect yourself in order to protect the users? So that's what we call the 5 Cs model, which is recently actually it's been published in support of the member states to fight against vaccine hesitancy or to increase vaccination acceptance for the member states, which I find very useful. It comes from the 3 Cs model from the WHO and has been recently with research expanded to 5 Cs. Next one. And another component with regards to why we are here, and I think it's really important to mention, is related to immunization financing. What we know is that almost 80% of the European countries spend less than 0.5% of their healthcare budget on immunization, which is, if we look at how much it costs per capita, is just about €5 per head or less that is spent on immunization across Europe. And this has an impact because the level of financing that you inject in such a system should translate into performance. And clearly across Europe, we have an issue in terms of performance of the program. If we look at the context of the pandemic, clearly we've seen an issue with regards to the resilience of the immunization system across Europe, with difficulties to maintain routine vaccination services in the context of the pandemic. There has been gaps and delay in the rollout of COVID-19 adult vaccination. We have managed to achieve the impossible, in fact, with 70% coverage rate in 9 months, but this hasn't been without a significant political push. I think we all should acknowledge that, and engagement never seen before because of the pandemics. But in the absence of such a push, adult immunization is not actually well supported by the programs today. So there is an issue in terms of ensuring that an adult vaccination is well implemented. And the delays that we've seen with COVID-19 demonstrates that we were not ready to support the implementation of adult vaccination. And last but not the least is a delay in access to novel vaccines. It's worth mentioning that a new vaccine to access markets can have a median time of 6 years. And 6 years is very important. You have a third of that in medicines in general. So worth acknowledging the delay in access to novel vaccines. What do we need to achieve? I think the beauty with regards to vaccination is that we can contain, eliminate, even eradicate potentially the vaccines preventable diseases. So where we are at with regards to measles, for example, we had a measles elimination plan a bit before. We had been actually kind of attacked, but surprised also by a measles outbreak just before the pandemics. The pandemics took place. Where are we at with this elimination target on measles? I think it's worth putting back on the table. There is a defeating meningitis goal by 2030 from the WHO, which is also a visionary goal and ambitious plan. There is a European cancer plan for Europe, which includes elimination of cervical cancer and other cancers caused by human papillomavirus. That is aligned also with the WHO elimination plan of cervical cancer in the world. So ambitious plans, and where we are at with our influenza vaccination, we are actually entering into influenza seasons potentially, and are we ready to ensure good implementation of influenza vaccination alongside to COVID-19, for instance. So what do we need to achieve, or what do we want to achieve? Personally, I dream for a Europe free of vaccines preventable diseases and cancers, but a lot to be done in the meantime. So immediate actions that we put together for policy makers in order to support the effort to recover, but also improve the vaccination rates. The first one is really the importance to prioritize routine immunization as an essential service across the life course. Vaccination is primary prevention, is a key public health tool that is major to support the resilience of healthcare system, and ensuring vaccination is accessible at all stages of life with the right support beyond pediatrics is critical. Ensuring the awareness of vaccines preventable diseases in adults is critical today. We need to ensure that every member state understands that vaccines is not for kids only, but for all individuals that has relevance in being vaccinated. The second point is with regards to access to immunization services. We've seen that the pandemics creative ways to ease access to individuals in adult sphere, because COVID-19 was specific to adults, has been done, whether it was mobile clinics, but more than anything else is within the system, everybody should be able to have access to vaccination depending on where they go within the system based on their health profile. You're a healthy person, can you just have to go through a nurse's or a pharmacist, for instance, to be vaccinated, rather than going into the complex health systems. If you have underlying condition, can you just rely on your specialist to have information and access to vaccination, rather than moving to separate healthcare professionals? So how we can ensure that the access to vaccines and vaccination and information is easy within the healthcare system through expanded delivery services. Ensuring financing for vaccination programs, this is what I covered earlier. So immunization financing, sustainable immunization financing that is linked to the performance of the programs is critical today, and we were very far from this. Strengthen immunization data system to ensure that we have timely monitoring of all the programs that are in the national programs. It might be worth to have monthly monitoring for some vaccines, by every 6 months for some of the vaccines, but ensuring that the monitoring is done to ensure that decision making is well supported, and that right campaigns on to ensure high vaccination uptake at the right moment of the year. And last but not the least is related to communication. Building trust and confidence in vaccination is critical. The healthcare providers here plays an important role. They are the first trusted source of information by the population. And here again, ensuring that they are trained and educated appropriately across the curricula is very important. But also ensuring that the population knows where to find the right information related to vaccination and how to direct them towards this right information is critical. I'll pause here. I thank you all very, very much for your attention.
Georgia, you are muted.
Hello?
Yes.
Can you hear me now?
Yes, yes.
Good. Sibylla, that's an absolutely great start to the meeting. You have posed some great questions already. I wonder if our government realised the healthcare savings in finance. You mentioned less than 0.5% of healthcare budgets, and the amount of money that saves in terms of healthcare is huge. But we may come on to finance later on, but Sibylla, thank you very much. That's a great start for us. Now, before we get into discussion, we have a short video from Tomislav, who is an MEP. He wished to be with us today, but he's been called away, but he's been kind enough to send a video. So if you can show that, please, Ruben, and then we'll get on to discussions.
Hello, I would like to thank FEAM European Biomedical Policy Forum for organizing today's event. I was greatly saddened to hear that the COVID pandemic caused cancellations of regular vaccination appointments across the European Union. Vaccination is one of the most important public health measures we have, and any irregularities in vaccination schedules across Europe threaten the health of our citizens, especially the most vulnerable ones, such as the immunocompromised, children when it comes to diseases such as measles, or the elderly if we talk about the other side of the spectrum and the regular annual flu vaccinations. However, the most important lesson learned in this pandemic is that all communication about vaccinations from public health experts and public officials needs to be as transparent as possible, addressing any and all doubts about the safety of the vaccines, the necessity of vaccination, and other key public health issues. That pertains not only to the new vaccines comparable to the one for COVID, but also to the previously available and well understood regular vaccines. Another key lesson from the COVID pandemic is a need for more unified European public health policy, and especially common responses to health crisis. The European Commission and the EMA had to implement an ad hoc approach to the COVID pandemic, although the experts had been warning for years that the global pandemic was unavoidable. A common European policy, based on well-designed legal framework, should provide us with a better response to future crises.
Good. Well, as I told you, we've always been keen in the forum to have communication with the Commission, because that's where a lot of these decisions are made, of course, for Europe. And before we go on, I must say that a map of Europe that Sibylla showed had a blank for the UK. And my sadness in Brexit is easy to express here. And all I can say is I've spoken to Public Health England this morning about this topic, and we have exactly the same problems, particularly with HPV, with a big drop, principally due to school closures, and measles, which of course is so highly communicable. We're very concerned that there may be measles cropping up. So apologies for Brexit. That's all I would say in this area. Well, we should start now. Just I think a quick round table to introduce ourselves. And if I can just call out a name, and then if you briefly introduce yourself, and so we know just where you're coming from in terms of your expertise and what you do. So Sibylla, can you just tell us a little bit about Vaccines Europe, and then we'll move on.
Sure. So as mentioned, Vaccines Europe represents the vaccines companies in Europe that have small size as well as medium and big size companies. And our aim is really to ensure, so we drive to build a resilient immunization environment in Europe for the population, for the citizens, and ensure access to vaccination across the lifespan. So the life course approach to vaccination, value of vaccines at all stages of life is in our DNA.
Yeah, thank you, Sibylla. So Martine?
Yes, hi, good morning. Good morning, everybody. I'm Martina Ingwersen. I work for the European Commission as a policy officer in our unit for health security. What I can say is that we are, of course, still quite busy with the COVID-19 vaccination, but we have also for many years been working on vaccination in general. And we are slowly getting up the pace again on these matters after having worked a lot on COVID-19 vaccination. As for myself, concerning COVID, I have not really been working on the contracts, on the strategy as such. I've been working on the rollout, the deployment in member states, which is actually a national competence, but we have supported member states in having everything ready for this rollout. And as you know, we recently reached the 70% of having fully vaccinated the adult population. So this is a great step forward, but there's still a lot of people who actually did not receive the first vaccination course yet. I guess I will come back to our other activities, our activities on general vaccination during the panel. So I won't say much now. But just to introduce myself, I work on COVID-19 vaccination, but I also work on vaccination in peacetime, so to speak.
Thank you, Martine. We will come back to you, of course, on catch-up. Thank you very much.
Thank you.
Marcel?
Yeah, let me unmute. Hi, good afternoon, everyone. I'm Marcel Levy. I'm professor of medicine at the University of Amsterdam, the Amsterdam University Medical Center, and at University College London. And I'm also the president of the Dutch Research Council here in the Netherlands. I've been involved in vaccine trials, mostly COVID-19 vaccine trials, when I was working in London last year, and now I'm involved with the same in the Netherlands.
Good, thank you, Marcel. We will be getting back to you as well, particularly about the COVID trials. And then we move on to Bianca.
Yes, good morning, everybody. My name is Bianca Freyallo. I'm a pharmacist, and I'm also a patient advocate, as I work for Active Citizenship Network. That is a widespread and flexible European citizens network. It was established in 2001 as a European branch of an Italian NGO called Cittadinanza Attiva. And our main objective is the promotion of civic activism and participation in political arena and the protection of citizens' rights. And we are deeply involved and active in the European national debate on citizens' rights, and with a concrete interest in improving their protection across Europe. Our network is composed by more than 2,000 civic and patient associations across Europe, coming from 34 countries and 22 European and global network and umbrella organizations.
Thank you very much, Bianca. So your remit covers more than vaccination, presumably.
Indeed.
Yeah, good. Thank you. And then Tony.
Yeah, hi everyone.
Hello, Tony.
Hi, my name is Tony Andreu. I am the scientific director of EATRIS. EATRIS stands for European Infrastructure for Translational Medicine. This is an organization which was created by the European Commission and owned by the member states, belonging to the European Science Forum of Research Infrastructures. We represent an alliance of 110 research institutions belonging to 15 European countries. And our role is to accelerate the process of translational medicine, interconnecting the scientific community with the clinical side. We have, as our main goal is to provide services, scientific and technological services for the acceleration of translational medicine. And we have strong platforms for vaccines and immunotherapy with 50 research institutions that develop scientific projects around the vaccine domain. Thank you.
Good, thank you, Tony. So like Bianca, you have more than one remit, but vaccination is clearly a dominant one.
Indeed.
Good, thank you. And then lastly, we go on to Attila.
Thank you very much, George. Hello, everybody. First of all, thank you for the opportunity for joining this conversation today, which I think indeed is a very relevant and very important topic. My name is Attila Mihai, and I work at GlaxoSmithKline, and within that in the vaccine division. And I'm leading the vaccines medical affairs teams for GSK across Europe. And me and my colleagues in the medical affairs teams and across the organization, we're primarily focused on developing innovative vaccines that address unmet medical needs, and particularly passionate about efforts to improve the understanding of the value of vaccination, of life course immunization, and advancing the access to immunization at all stages of life. So I'm very glad to be here and looking forward to this discussion.
Good, thank you very much, Tony. As one of my friends said recently, I'm glad to be anywhere. Well, I think we're all very pleased to be here for this discussion today. Well, you've all seen some questions that the FEAM team has assembled, and feel free when we look at each of these questions, I will direct them to one person specifically, but then anyone can come in. And if there are specific things that you wish to talk about, please add them on the chat. So I wonder if I can ask Sibylla, first of all, has this drop-off in routine vaccination been consistent through European countries, or do you see ones which are particularly vulnerable? And I would think, of course, of low-income countries which are in a difficult position for healthcare sometimes. So do you see differences between countries?
There are differences between countries, surely. George, the issues that we have is we cannot compare, because we don't have an exhaustive view of the situation in Europe. But what we've seen, and the WHO Europe, which has an extended regions compared to the European Union, notified that some countries, including Romania, for example, had definitely seen a drop, notably in MMR, below the 95% that is required to avoid an outbreak. And we've seen on MMR, particularly a drop as well in key countries such as Italy, Denmark, if I'm correct. Need to check on those countries. I should have actually learned them by heart. So we have key countries that have seen an issue with MMR. Overall is a drop in vaccination coverage for all pediatrics, but it's been recovered in many countries, like as presented in Greece, for example. We've seen a recovery following the engagement of the local scientific societies and the engagement of the government. But the issue is rather the lack of data, comparable data across the region more than anything else today.
Yeah, well, you mentioned that right at the beginning, Sibylla, a lack of national registers seems to be the dominant thing. Although it's interesting, as I said, we have a very similar figure for HPV lack in the UK, 65% drop in vaccination, which is going to be hard to catch up in adolescents. But a national register. Could I ask anyone on the panel if they're aware of national registers in their own countries? Marcel?
No, we don't have such thing in the Netherlands. So there is a national vaccination program, but there is no national registration.
Right. And Tony, are you aware of national registers?
No, what I think in some countries, Spain, which is my home country, and I know it pretty well, it's a very interesting case because the healthcare system is basically public and that has been completely decentralized to the regions. So there is strong differences in the regions, and some regions do have this kind of registry. There is, unfortunately, at the member state level, there is not an harmonization on the policy and indeed not a national registry or harmonized database.
Yes. Any other countries that would like to come in and say, yes, we do have a register and it's freely available? Or is this a common thing that there may be a register, but it is small? Attila, do you know of any?
Well, I mean, national registers, I think UK is one of the countries actually that has the strongest system on monitoring the recommended vaccinations and actually provide periodic updates on vaccine coverage through Public Health England. And I think that was one of the countries also that actually provided some very insightful data on how the adult vaccination was impacted, because what Sibylla was mentioning is a really interesting dynamic. When we look at the impact on vaccination coverage, based on the data we have, I think in the pediatric space, we do have, even if it's not national registries necessarily, we do have strong understanding of the vaccination uptake and the gaps therein. What I think was really important in the disruption is that if we look at the whole year of 2020 and up to now, indeed, we don't see a huge drop in vaccination coverage overall in the pediatric space. But if we break it down, and I think I will come to the point why I think it's important. In the first few months of the pandemic, there were big drops in pediatric vaccinations, some up to 60%, depending on the age category and the type of vaccine we look at. On average, WHO, as Sibylla mentioned, WHO Europe, 22% of vaccinations continued. But then the pediatric society and the pediatric vaccination infrastructure was able to monitor this and pick this up. You can only pick this up and close this gap through catch-ups if you know who were the children that had to be vaccinated and you were able to reach the parents to arrange for catch-up vaccinations. This system does not exist for adult vaccinations. And I think the HPV vaccination that you mentioned is a borderline between the two. Targeting adolescents is difficult. UK is in a rather privileged position through the school-based immunization programs. Countries who don't have it, I think, had no chance to actually catch those adolescents through the vaccination. And when we look at the registers, who has registers in the countries, I think one of the key points, but I don't want to put the carriage before the horse. We have now vaccination registers in pretty much every European country thanks to COVID vaccination efforts. And I think that will be probably a point for later in the conversation.
Yes, well, exactly. We will be coming back to that, Tony. What can we learn from COVID vaccination that could then go to enhance the routine schedules? If I may, I can tell you what the UK system does. I have access to my NHS National Health Service record, and on that there is a section which relates to immunizations. I got my first two COVID vaccinations, for example, in January this year, and then 12 weeks later. I had a booster 2 weeks ago, and that was immediately put from the site onto my record. So I can call that up straight away. And that's very useful because I can get a vaccine record to show when I'm traveling or whatever. And that is accessible by what is now a different organization. Public Health England was scrapped a few weeks ago, and we now have a new public health system working, which has taken that over. But I can see exactly what vaccinations I've had, and similarly for influenza. Sibylla, I see you have your hand raised.
Yeah, I just wanted to share your beautiful tools that exist. There is one in France that is called mevaccin.net. Also, I'm Brussels-based. I'm French by nationality, and I registered that years ago to a system that is called mevaccin.net, which actually is citizen-centered. So it's for you, and that you can share with your doctor. But the beauty of this tool is that it collects a bit of data about you, who you are, age, gender, but also occupation and underlying condition if you have any. And these tools read in a very clever manner. So it's not artificial intelligence because there is a group of experts behind it, but which vaccines is good for you as an individual, because I would take the example of a pneumococcal vaccination, for example, may be more relevant for some type of populations than others. And the tool actually delivers the information as well. So for instance, you have kidney failure, for example, the tool will say, well, you have kidney failure, you're 20 times more at risk of a pneumococcal infection than any normal individuals. This is a vaccine for you, or this vaccination for you. And I do still receive actually regular updates by email. It's up to you how to set it up. And I received the one on influenza recently. So what I liked is this personalization about why this vaccine is good for you, provides the scientific relevance, and really engage me about willingness to be vaccinated with that specific vaccination. So I registered my girl as well, although now she's on the Belgium system. So we have an issue with regards to the recommendations, because pediatrics recommendation and scheduling in Belgium is not the same as the one in France. But that's apart. That's something else, but that's a part. I find this tool really beautiful because it provides a personalized recommendation of the vaccination that is needed depending on who you are.
Right. So in France, it is possible for an individual to find out what vaccines are available for themselves, and also what vaccines they've had and the date that they had for the whole of France.
It is available for the whole of France. It's a matter of people and citizens to log into it, and then to ensure that this tool is integrated to the rest of the healthcare system so that you have the monitoring.
And is that accessible to central public health bodies and to the general practitioners, so that there could be good surveillance throughout the country?
Absolutely.
Good. Does anyone else have any other comments from their own countries? Marcel, Holland is so well organized for health, in my opinion, but you said you don't really have a system like this. Is that correct?
Yeah, that's correct. So the vaccination record is stored in the physician's records, but there is no central registry. I think the country is very averse to central registries. So even less so than any other country in Europe. So we won't have a central registry.
Right. And that pertains for all of healthcare, does it? Not just
well, there is now COVID-19 registry, because we need it for access codes and green passes and whatever you call it. But I don't think there is somebody who is capable of looking into that. It's all on an individual base.
Right. And anyone else, any comments on that, please, for their own country? So France and the UK do have systems which are accessible by individuals and centrally. Anybody know of any others? In Italy, for example, which of course was early in the COVID.
Yes, actually, we do have a register, but for sure, I think that we have some good examples and good lessons that we can learn from this pandemic. I mean, because, for example, what we have in Italy is also a special scientific committee for post-marketing surveillance on COVID-19 vaccines that has been established in December 2020, and it is supposed to remain in office for 2 years, but of course it may be renewed based on the evolution of the pandemic. And the purpose of this committee is to ensure an active surveillance on the safety of all COVID-19 vaccines that arrive in Italy. And it is composed by high-profile experts, of course, of proven scientific independence, and it ensures transparent judgments on the full safety of these vaccines and a full compliance with the protocols followed in the vaccination campaign. But one point that I would like to stress, and I think is important, is that in addition to the experts, this committee is also composed by observers with the task of ensuring that information is timely and complete. And among these observers, for example, there is also our president as a representative of civil society. So I think that one good lesson that we can learn from this pandemic is the great importance of a multi-stakeholder approach and a multi-stakeholder collaboration, because of course it's important to hear also to the citizens and the patients. Not only, of course, all the healthcare professionals.
But is your register purely for COVID, or do you have the routine vaccinations?
No, we also have a register for routine vaccination, but as also Sibylla pointed out, unfortunately, we don't have all the data available. I mean, sometimes, for example, at regional level, we don't have all the information available.
Now, why is that if you have a system? Is that because people aren't entering the data, or individuals don't know about it, or doctors don't know about it? What's the, is there a reason?
Yeah, I think that the main problem is that we sometimes we saw let's say an incomplete situation with between the regions, and sometimes also inside the same region we don't have the systems that talk, let's say, between them.
Okay, so we have France and the UK with complete registers. We have Holland, which is averse to having healthcare registers anyway, with the exception perhaps, well, with the definite exception of COVID. Anywhere else would like to, any other countries that would like to comment on that? Attila, do you have experience when you're looking through the GSK vaccines of these sorts of things?
Yeah, I mean, when we're looking at the utilization of our vaccines, is a lot of the times it's our own internal databases that tell us what is the actual distribution of different vaccines to different countries. When it comes to actual vaccination rates confirmed by the countries, because obviously no manufacturer has oversight on all other vaccines in the similar disease. If you look at just the traditional pediatric vaccines like the DTP combination vaccines, there are multiple manufacturers who are supplying. So just looking at what we do is not giving us a full picture. I think overall on the pediatric scale, however, we do have, talking about the DTP vaccines, we do have these vaccines that are frequently used as proxies, as indicators of vaccination coverage. And there are targets set around this, which is currently around 95%. And this is being monitored, and it's fairly reliable. So I think in that space, even if perfectly synchronized registers and communicating healthcare databases might not be available readily in all countries, the DTP and the measles containing vaccine coverage rates gives us good overview on where do we have successful programs in place and where do we have potential pockets of risk for outbreaks or endemics to occur.
Thank you. That's very important. One of the things we've been doing with adult vaccination in FEAM is looking at schedules throughout Europe, and it's completely haphazard, actually. Germany and the UK seem to be the best. The vaccines are available in all of the countries, but there's no register and there is no schedule. And that's one of the things which has stuck out and somewhat of a surprise. Member states of the EU don't seem to be willing to say, right, why don't we have a common, simple schedule throughout the Union, which is easily accessible and recordable. And that seems to be an impossible aim. Now, on top of all of that, we have this wretched problem of vaccine hesitancy. And we are up to 70, 75%, maybe even nearly 80% for COVID in some countries. But it seems that that number is going to be difficult to exceed. What about obstacles to vaccination? I mean, it seems that with COVID, we have enough vaccines now, we have distribution sorted out, just forgetting the third world at the moment. And yet getting above this magic number and getting teenagers vaccinated now in the UK is proving to be quite a challenge. So what are the real obstacles? And Attila, I wonder if you could think about that and think about vaccine hesitancy as well, please.
Yeah, happy to, and I'm sure many of the panelists will want to chime in on this.
Yeah.
I think vaccine hesitancy is a topic. You're probably familiar with the works of Heidi Larson, who's done an enormous amount of research on this topic. And vaccine hesitancy in her work is summarized basically as a phenomenon that has been there since the very beginning, since immunization started. And she very elegantly framed it in such a way that vaccine hesitancy is not a battle to be won. It's a battle that we have to fight. It will not go away. And I think vaccine hesitancy, as Sibylle already alluded to it, is not just people being opposed to vaccine. There are several elements to it why they are hesitant to take the vaccine or simply just complacent to take the vaccine. And bringing up the COVID experience, I think there's a lot of interesting lessons to be learned around this, certainly in the vaccine hesitancy topic. If you think back around mid-2020, when the vaccines were still in development, there were several surveys that came out, also in Europe, indicating that 40 to 50% of the adult population would not take a vaccine even if it was available. Yet here we are today, and as George correctly mentioned, I think the one-dose coverage for COVID-19 vaccine is around 79%, and full dose, so two-dose coverage for two-dose vaccines, one dose for the J&J is around 74%. So I think that's to me an indicator that opinions around accepting the vaccines will evolve. What were the key factors driving this? I think if you remember in the beginning, there was a huge amount of anti-vax content on online platforms, social media. And during the development also, when certain adverse event data came to light, there was huge amount of media attention to it, which did generate confusion. But by and large, I believe that one of the main reasons why the COVID vaccination has reached this 79% coverage rates in the adult population, which if you compare it to flu, which Sibylle already mentioned, we've been working decades to reach this level of coverage in influenza, and we only succeeded in a handful of countries. So this is, I think, a proof that it can be changed through clear communication, addressing the target population that needs to understand what is the risk of the disease and what are the benefits of the risk of the different preventive measures, including vaccination. And I mean, including other preventive measures as well, because it's not just vaccines that we're questioning. If you remember in the very beginning about mask wearing, there were huge debates whether it's the right thing to do, not the right thing to do, whether it helps or not. So I think clear communication in a language that people understand, and also through people that they listen to. And in this part, healthcare providers and healthcare workers still remain the #1 source of information, has played a major role in reassuring people that taking the vaccine is the best thing they can do for their own health and for their environment. How to reach the remaining population, parts of the population, I think similar strategies will need to follow. If we see now that the vaccination rates are lacking in the under 40 population or amongst the teenagers, we need to target them. First of all, understand what are their concerns, what are their motivators potentially, and engage in the dialogue with them. But this requires time, this requires effort. And if we go back to the sub 0.5% investment in vaccinology, we need more resources to do this. I'll stop here to give floor.
Yeah, thank you, Attila. You know, one pedantic point that I often raise in meetings like this is, in some ways, vaccine hesitancy is perhaps a natural thing. You want to know more about it. You're hesitant because you wish to know. It's vaccine refusal, which actually is the crucial thing. And unfortunately, vaccine hesitancy is stuck now as the way to describe this. And we're not going to change it. But I agree, education, and good communication is crucial. Marcel, in the Netherlands, you have a sophisticated healthcare system. Do you have vaccine hesitancy even with that background?
Oh yes, absolutely. But I'd like to echo what Attila was saying. So the group of people who really do not want to have vaccines, who refuse all types of vaccines, is very small. It consists of people who have certain scientific beliefs about immunity, and it consists of people with very fanatical religious beliefs. But these groups are extremely small. And then there is a much larger group, which amounts now for COVID to 10% of the population, that is really misinformed and has all kinds of concerns in terms of fertility. Well, you know all the stories. Yes. About side effects, about incorporation of RNA into DNA, and so forth and so on. The only thing I would like to add is I think what we do, communication is key, but what we are probably not doing very well is to really communicate with these people. We are telling them all the time that they should do this and that they should do that and that they're stupid and that they don't understand and that they really don't get it. But I don't think that that's going to be effective. So I think we need to listen a little bit more to these people, use key opinion leaders, just listen to their concerns, and then try to address that with not only experts, because many of those people do not believe in experts, but with key opinion leaders. And then we just go percent by percent every week. It's a battle. I absolutely agree with that. But I think we're sending a little bit too much and we're not receiving sufficiently.
Thank you. Very wise, Marcel. Attila, you had a comment there, I think, and then Tony.
Yeah, so just real quick, I think this is a very important point that Professor Levy just brought up. We need to listen to understand first where the concerns come from and address those. And this has to be a dialogue. And if we tell these people what needs to be done, or we stigmatize them, discriminate them, or tell them that they are wrong, this is probably going to be counterproductive. And one other point that I wanted to still mention is, which came up from the conversation, is education it was really important in the COVID vaccination rollout. But I think the other one was the access to vaccines. So the vaccination points, expanding the number of vaccinators, and making the logistics as easy as possible for the adult and elderly population has played a huge role in being where we are today.
Yeah, just on that point, before we go to Tony, in the UK, we decided to have HPV vaccination for adolescents, both for boys and girls now, within the schools. And a child could refuse if they wanted, which is very interesting, because a 14-year-old could refuse to have the vaccine. But by going to the schools, this has really given excellent coverage for adolescents, and our HPV program was going very well until the schools were closed down for COVID, and we've got a big catch up to do now. Tony, and then Bianca.
Yeah, I would like to add to the discussion, reiterate the importance of the, let's say, the communication layer. And of course, we need to make the concept of vaccine development accessible to the public. But for establishing these policies, we have to have the public on board. Most of the time, policymakers, we tend to establish these top-down communication strategies that do not really take into account the perspective and the vision of the public, because they are not brought to initial phases of the development of that particular policy. So that multi-stakeholder concept that Bianca mentioned is absolutely fundamental for the future development. And I think it's very important that part of this hesitation that exists in the average population for the vaccine is common to some sort of general hesitation or historically present in the drug development process that the pharmaceutical industry knows very well. And there's this kind of stigmatization of the pharmaceutical industry as money makers, that they have this kind of as their primary goal. And of course, this is something that many stakeholders, the pharmaceutical industry at the first stage, have been working on over the last few years. And I think this is little by little, this is being counteracted based on policies of transparency. And bringing transparency to the process is essential. And the last but not the least is that I think in this communication policy that establishes the bridge in between the society, the societal fabric, and the policymakers, the science domain, the pharmaceutical industry, the healthcare domain, there is one stakeholder that we usually forget, which is the media. The media have to be also involved in the development of these policies. And I vividly remember, and you all remember, that when the vaccines were, the rollout process started after the approval of the regulatory bodies, everything based on this 100% safety and efficiency, almost 100% anyway. When we start having the first cases of some side effects, strokes with some vaccines, the media were kind of amplifying the message. And I remember headlines at the prime time saying, how do I know if I have a stroke? Which are the signs of alerts? This is an artificial amplification of the message that is given by one specific element of the society that has to be also brought on board for establishing a common understanding of the challenges and opportunities in the process.
Okay, thank you, Tony. So media are important, and the right message from media is important. I'm going to go on to Bianca, but Martine, I'm going to ask you in a moment, are there any things that central policymakers can do and are doing about hesitancy? But first of all, to Bianca, and then I'll come on to you, Martine.
Thank you, George. Actually, I can agree more with what has been just said, and regarding the multi-stakeholder approach, it is at the base of our work. For example, we carried out a survey in the period between December 2020 and May 2021 in order to look at the impact of the pandemic on routine immunization. And we carried out this survey at the European level, and we received answers from 21 countries, and in this case we involved not only patient advocacy groups and citizen organizations, but also healthcare professionals and national health institutions dealing with vaccination, but also pharmaceutical companies. So at the end, we used this survey as a sort of virtual focus group. And we decide to focus in particular on influenza, MMR, HPV, and we saw that, as we said, no major impact on flu vaccination we had, but the situation was very different for MMR, and especially with HPV. What we saw that is that we need a strong support for digitalization And as we said, media and communication role is crucial. Because we need to have a strong univocal communication. Otherwise, citizens and patients will be confused. And this will go through vaccine hesitancy and other problems of this kind. And if I may add just a quick thing, we're running a second survey at the European level. And the deadline is the end of November, and all the details and information are available on our website. And in this case, we will focus on this new flu vaccination campaign and the concomitant deployment of the COVID-19 vaccination. So we would like to bring out the opinions and concerns of these various stakeholders involved in the different countries.
Okay, thank you, Bianca. Now, Martine, I've lost your picture.
I'm here.
Oh, there you
I
are.
hope you can still see me.
This idea on hesitancy and what we can do about it. Are you looking at this in terms of policy in a major way at the moment, or are you happy that COVID, for example, is as good as we might get?
I would say, of course, we're looking at it because hesitancy is a major threat towards what we call sufficient uptake of vaccines. But normally we actually prefer to say, instead of saying that we're addressing vaccine hesitancy, we say that we want to increase the uptake of vaccines.
Yes.
Because, I mean, hesitancy, you can do a lot of monitoring, but it's actually not all people who are hesitant who do not take the vaccine. This is important. And I'm afraid that we sometimes lose ourselves in big discussions about how to address vaccine hesitancy. And of course, the phenomena are linked, but what we like to say is that we work to increase the uptake of vaccines. And this is what we do in many ways. It's also about not saying that people are hesitant when, for instance, it could be people who simply miss the opportunity to have a vaccine without having any serious problem with vaccines. I mean, it could be people simply not having this done. It could be people for whom the obstacles are simply too many. I mean, you have countries where you need to go to your pediatrician to have a prescription, go back to the pharmacy, get the vaccine, go back, have an injection for your child, go back again and have a reimbursement. I mean, then it's no wonder that people do not have the second MFR vaccine for their child, for instance. I mean, this is where we could also work. And this is actually what we want to do, because in our new EU for Health program that you may have heard about, we have one big project on physical obstacles to vaccination, because we actually believe that this plays a bigger role than we actually thought. I mean, we're focusing a lot on confidence in vaccines, on addressing people's safety and the concerns about safety, and this is very, very important. But it's also important just to make sure that this is something that you just do. It's an obvious element of proper childcare, basically.
Yep.
I mean, it's another way of speaking about this, but terminology is important. And you may have seen the new document from the European Centre for Disease Prevention and Control. They have actually collected interventions that countries are implementing to increase the uptake of COVID-19 vaccination. And they do not speak so much about hesitancy. They do, but on the title, they call it how to increase the uptake of vaccines, because this is the focus and it needs to remain the focus.
Yeah, I agree entirely with all of those comments, Martine. Well, we'll be talking about ECDC in later on, and HERA, and how this might help. In the UK, probably 25 years ago, we had failure of the childhood vaccination schedule because the intervals between the three major pediatric vaccination steps were too long. And a scheme that was called the accelerated scheme was brought in, where there was 1 month between the first and second, and 1 month between the second and third of the vaccinations. That increased uptake by around about 65%. And these practical things that you were talking about, Martine, you know, parents who are disorganized, parents who have 2 or 3 children, and one of them is ill and they can't get to the vaccine center. All of those things are absolutely crucial. And as I said earlier on, it's such a shame that vaccine hesitancy has caught the headlines because it's vaccine refusal and the reasons for that that are important, and how we can get around those with simple things. And I've mentioned the accelerated schedule already, which we have used and we have in routine use now and have had for several years. Thank you, Martine. Attila, you had your hand up.
Yes, just very briefly, George, on commenting on what Martin just said, because I think it's a really important one. And if you have mentioned the pediatric examples. If you look at the adult vaccination, I think that the challenge of increasing vaccination uptake is probably even bigger, simply due to the fact that even the healthcare providers are not always aware of which vaccines are available to their patients. And if they don't know that, they won't engage in the conversation on why you should or should not consider this vaccine, let alone scheduling appointments to get vaccinated, which ultimately leads to the fact that we are still spending lots of public health money on diseases that could be prevented. And adults are not aware that they are available. Physicians are not aware that they are available, therefore they don't recommend. And this is, I think, the first big bottleneck. And then comes what Martina also mentioned, then the access to the vaccines. Even in the flu season, in some countries, you still see you have to go first to get a prescription, then you go to a pharmacy, go back to the physician to administer the vaccine. These points have to be addressed, because otherwise we will not be able to get out of this vicious circle of low vaccine uptake. Absolutely.
And I just wonder, going back to that very early point that Sibylla raised, that 0.5% of a government's healthcare is used, the value for that is immense, absolutely immense. And politicians should really know that figure when they're talking about the future.
George, I'm terribly sorry. Just on that point that you mentioned, because I think it's so important. Because what you just raised is critically important. Imagine that all the effort that we have done to roll out the COVID vaccination programs was already in place because we have a strong adult immunization platform. We could have prevented a lot of the damage faster, which currently is estimated to amount to over 21 trillion pounds globally.
Yeah, well, we'll come on at the end of our discussion to think about what we can do for the future, and that is very important. One thing before we leave this uptake, we are having big discussion at the moment in the UK on compulsory vaccination. We've already introduced that for healthcare workers who are dealing with the severely infirmed older population in nursing homes. But the question that we're now addressing is, should all healthcare workers, nurses, doctors, ward orderlies, porters in hospitals, should they have compulsory vaccination? And this is really hitting the headlines at the moment. Martine, could you comment on that from the policy point of view, and then anyone else who would like to add, please? Are you addressing this in the EU as well?
Yes, we are, but here again, I do not speak on behalf of a specific country, and vaccination is very much a member state's competence. So, I mean, it's their decision, even though you might say that you have some sort of maybe moral obligation to take the vaccine if you're dealing with vulnerable populations, but that's another point of view. This is really up to member states. What I can say is that mandatory vaccination of no matter which group is one way of dealing with low uptake of vaccines, or of dealing with vaccine hesitancy, if you want. but you can see high uptake of vaccines in countries both with and without mandatory vaccination. So again, I'm afraid it comes down to trust again. I mean, if you have a government that you believe that you can trust, then maybe you're more prone to get a vaccination also as a health professional. Now, I happen to be Danish. We have high uptake of vaccines. We do not have mandatory vaccination for anybody. But this is because there is historically some sort of trusted relationship between the government and the population. Not of course, it's not all rosy, but it's there. Maybe more than in other countries. So it's very much it's a very complex phenomenon whether people, including health professionals, choose to vaccinate or not. And it's mandatory vaccination is one way of dealing with it, and I'm not going to say anything for or against, because it depends of the country.
Thank you. That's very wise. So a complex situation and very difficult to legislate, actually. So again, it's back to education and communication, isn't it?
Yeah.
That we were talking about earlier.
Yeah.
Marcel, you have your hand up, and then Tony.
Yeah, I'd just like to add to what Martina was just saying, because I absolutely agree. And talking from a hospital perspective, I think compulsory vaccination gives a false impression of protection for patients, because we all know staff can still get infected even when they are vaccinated and can still spread the virus to immunocompromised patients. So that means everybody needs to maintain all the hygienic procedures, hand washing, mask wearing, everything. And it doesn't matter whether you're vaccinated or not. We still have to maintain all these measures. And I think we give a false impression that if we say everybody is vaccinated, that the risk is very low for our patients, but it's still not very low. So I think it's the wrong message. And for me, then, making the balance between that and then making vaccination compulsory, which is actually really difficult in view of the integrity of the human body, etc. I cannot be in favor of that.
Yeah, well, and in terms of trust as well, of course, Marcel, I agree entirely. Tony?
Yeah, I fully agree with the comments that have been made. I think we have to shift the message from the compulsory side to a more proactive educational side. And I think that the 5 C's framework that Sibilla presented gives the key, which is the collective responsibility and using vaccination and the need to protect others. That's the critical point. And we have an enormous capacity of building a strong narrative, making people understand that when you get a vaccine, you are not protecting you primarily, you are protecting the community. You are building this brick, this wall of protection. And that is something that I got the feeling that citizens start understanding properly in the COVID-19 pandemic. Probably not before with the, let's say, traditional schemes of routine vaccination. So obviously this message, this narrative of the need of protecting others is very important.
Good, thank you very much. Attila?
Yeah, I just wanted to add to it and also to make this point clear from our position. I absolutely agree with everything what has been said, and I think there is no quick fix to these problems. So we need to continue education. People need to understand why they should be vaccinated, and it has to be their choice at the end to want to take the vaccine.
Yeah, well, you know, you'll all remember one of our prime ministers, Tony Blair, who famously said, education, education, education. Didn't do much about it, but that summarizes really, well, if you add communication to that, education and communication. And we are now having in primary schools education on health, simple education, care of teeth, and vaccination is one of those things without any compulsion. So people know and can make a choice. If you look at what's happening in the States with this immense polarization now, It's quite pernicious in many ways. Well, time is really getting on, and we could go on for ages with these things. We just have about 5 or 10 minutes left. And really the final part of the discussion is, what could we do that would be better for the future? I think we've learned a lot of things about COVID, and when you think about it, it's quite remarkable where we've got, both from the discovery, the manufacture, and then the implementation point of view. It is quite astounding what's happened. But we are concerned that there isn't enough cross-country information going on, and even within country, we're concerned about the future and how we can be ready. And I see there's one very nice chat that's come in about ECDC, the Stockholm-based organization that could have surveillance really buttoned up, so that there's immediate concern raised about epidemic situations. So if we can just think about what we might do for the future, using the COVID example, that perhaps that we could say this would reinforce an even quicker response, because we will have epidemics in the future. There's no doubt about it. Right, Sibylla.
Thank you, George. I mean, the point you raise is critical, and I do think that what I presented with regards to immunization financing is the key, I would say, door to open. What we faced with COVID-19 is a demonstration that we were not ready to implement an adult vaccination program. And in fact, we are not ready, if depending on where potentially the crisis happened on a specific part of the population, is are we ready or not? And we've seen with the discussion today that it is multifactorial. It's about the role of the healthcare providers in delivering trustful information and vaccination across the system to the different parts of the citizens. It's about right communication campaign to the citizens. It's about multi-stakeholder engagement, including the media. It's about the infrastructure, or every place, every place ready to deliver information and vaccination. It's about integrated, interoperable digital system to timely monitor the data. And all of this needs funding in a sustainable manner, in order to ensure that you have all relevant information, data. I mean, it's data, it has to be data driven to reach the relevant part of your system. It's a complex ecosystem with industry, policymakers, citizens, healthcare providers. So we need to invest, we really need to invest. And I think it is the nerf de la guerre, as we say. Without proper funding, we won't achieve anything, honestly. And today, what we know when I say immunization financing is not about procuring vaccines per se. I mean, they are cheap, they pay for themselves. €1 invested is at least €4 back in adult immunization. If we take the whole population, is even more than that. So they pay for themselves. So the value of vaccines is definitely there. It's really a matter of how we ensure that the system is resilient. And today we are far from that everywhere across Europe, because all the countries across Europe has been impacted with regards to COVID-19. And we have countries in the eastern part of Europe, like Romania, Poland, Bulgaria. They are really far compared to the western part of Europe. So we need as well to get those countries back to at a level that is comparable with the western part of Europe, because viruses have no borders. So if you have some part of your region that is not actually protecting well its population, it's impacting everybody. So I think the immunization financing topic is critical. We need to understand what we mean by it. I actually ask any country if they understand where the budget is coming from, to where it goes, and how it translates to performance of the programs. I think that in Europe, maybe the UK is a better placed, honestly, but no country knows how its budget is actually used in immunization. So immunization financing is really, really critical.
Thank you very much, Sibylla. Now, does anyone else have any final comment they would like to make or final summary before I try and draw one or two things together? Attila, you have your hand up.
Yeah, George, if I may, I think just building on what Sibylla mentioned, I think prioritization in terms of policy making and investment, both at national and European level, is a critical thing we need to do. And it showed also through the COVID example that if you do it right, it can have pretty fast impact. Moving beyond that, we need to build vaccine literacy in the general population, and particularly targeted to the adults, older adults, who currently are not at the level of understanding of what vaccination and prevention can mean for them. I think we need to continue expanding the vaccine access points to make it easy for people to get vaccinated, and continue developing and deploying further the digital tools that we have spoken about today to help monitor the system performance, to provide information to the patients, down to the very pragmatic aspects of making an appointment with the vaccinated. I think this is what we could take away from the COVID pandemic experience.
Thank you very much, Attila. Your and Sibylla's comments are very well taken. And I see a chat here from Sibylla. We need a one voice approach, a coordinated EU member states and inclusive multi-stakeholder approach. And I think that summarizes it all up. I'm sorry, but time is running out. And I really must thank you all for fantastic thoughts and discussion. From what I can see, first of all, the technology now is fantastic. The mRNA vaccines have revolutionized the way that we can do quick genetic manipulation and then incorporate that into vaccines, even with what we know about the older immune system and adjuvants. They are working well. So we have that to be thankful for from COVID. What we have not to be thankful for is the time that it took to recognize epidemic and then pandemic. And one of the things which I know the EU is thinking about very much is strengthening the ECDC. And I mentioned that in terms of surveillance and rapid response to that surveillance, and to have an organization called HERA, H-E-R-A, which is similar to the American BARDA. This has been approved, but perhaps not with the strength that it might have had. And I suspect that as time goes on, and particularly if we have another pandemic, or if COVID remains the pandemic that it still is, then that may have to be strengthened. But we have to use COVID and what we've learned for the future. There's absolutely no doubt about that. We were undoubtedly caught out short by this. It took a long time to recognize, took a long time to get even lockdowns organized. And we still have a lot of public disquiet because of lack of information and wrong information that's gone out. Well, we could have gone on for ages, but we all have other things to do. But I hope this forum meeting has invigorated people to think about, first of all, simple things we can do: communication, good data collection, and making a common view within countries, between countries, so that we can respond more quickly in the future. So thank you all very much for absolutely expert and very, very cogent comments. So with that, I'll close the meeting and keep on. That's all I would say. Thanks very much, everyone.
Thank you very much. Thank you.
Thank you.
Thank you.
Thank you. Bye.
Bye-bye.